today. So maternal OCD have asked us to make this video because they would like us to kind of explain what it's like to have a psychiatric assessment. So I'm Alexa, I'm a clinical psychologist here at the Centre for Anxiety Disorders and Trauma. You are Paul, you're a psychiatrist in training, also here at CADA with me. Do you want to say anything more about yourself?
Hello, hi Alexa, thanks for inviting me to this talk. I also work in CADAT.
So this is an anxiety disorders clinic, and we see a lot of people with OCD, don't we?
Yeah, I do, yeah. Nationally, yeah.
For me specifically, I work in CADAT PACS, which is the perinatal part of the service. So I see a lot of mums and pregnant women with OCD. So if I'm to kind of take the role of a mum with OCD, let me ask you, first of all, what does it mean if I'm asked if I want a psychiatric assessment?
Yeah, so I think a psychiatric assessment is basically it's a comprehensive evaluation of a person's kind of their mental health, kind of their past mental health and the current kind of mental health, and by mental health professionals such as a psychiatrist.
So, but it's a little bit different from, because there's overlap in our roles, you know, being a psychologist, you being a psychiatrist, we overlap in some ways, but there's also some key differences. So in terms of psychiatric assessment, particularly, I mean, let's get into the kind of specific questions that might be asked. So what might be the first thing you would ask me, say, if I came to you with OCD?
Yeah, I guess the first thing, I guess, will be just to get an idea from the client, and sometimes from the family as well, of the main kind of problem, the OCD problems that's kind of been troubling the client. So I guess in OCDs, I've just been asking the mom about if they have been having any kind of intrusive or very unpleasant thoughts or images, things that have been troubling them. And so that's part of the obsessions. And I guess we're going to ask about how they kind of manage those intrusive thoughts. A lot of people, they engage in what we call compulsions. Could be kind of like ritualistic behaviors, or sometimes going through things in their head, like counting certain numbers and things. They do these compulsions to try to kind of manage the obsessions. So I guess I'll try and take a pretty detailed assessment to see what the mom's at in terms of whether she's having these thoughts or kind of compulsions, and after that, to come up to get a sense of the problem, what's troubling them, and also how's that these symptoms impacting on her life and on those around her at the moment. Yeah.
And what if I'm having thoughts about harming my baby as part of my OCD? Like, can I trust you to sort of understand that, or are you going to call social services on me, or what can I expect if I disclose those thoughts at a psychiatric assessment?
Yeah. So I'm actually having these thoughts of harming baby is actually a common type of intrusive thoughts that people have with OCD, particularly in mothers with children or babies. So it's very common. We see that a lot. So
you're used to that, you understand that?
Yes, absolutely. Yeah.
Great. And again, in terms of like drilling down to the specifics about what I'll be asked, so the differences between speaking to a psychiatrist versus a GP or a psychologist, for example, you would do what's called a mental state examination. Can you say a bit about that?
Yeah, sure. Yeah. Basically, it's part of the assessment. It's an interview, or it's just a conversation with the client, and it's just to see to ask them about how they're feeling themselves at that moment in time. So I mean, part of that will include how they're feeling in their mood, because as you know, people with OCD, particularly severe OCDs, they're very debilitating, and very often because of that, people feel very low in mood. And so we ask that to see if there's any other problems going on, make sure that are they sleeping all right, are their appetites been affected, and so this is all kind of part of the kind of assessment of the mental state.
Okay, so you're asking about sleep, mood, appetite, all kinds of different variables to do with mental health.
Yeah.
And what other kind of questions might you ask, like once you get beyond the main presenting problem? Anything else you would ask?
Oh yes, it's usually it's just to get a bit about more background about the person as well. I think we start with, sometimes we start with what is it like for them growing up as a child, and can ask about their kind of family situation, and also I guess in terms of OCDs, about the history of how the OCD first started, because in a lot of cases, I mean, we see mom with OCD the first time, but it might not have been the first time that they've been having these problems. A lot of them might have been suffering for a long time before they actually come to seek specialist help. So it's very helpful for us to get a timeline of things and of their condition. Yeah.
I see. So you're doing main presenting problem, impact of the problem, you're looking at the background, you're doing the mental state examination.
Yeah.
What about if I'm having like scary thoughts, like suicidal thoughts? How would you sort of assess those?
Yeah, so I guess that's, yeah, that will be we do risk assessment as part of the psychiatric assessment. So it's a key part of our assessment. Um, yeah, especially when people feel very low and feel so impacted by the OCD, people do sometimes have thoughts of not kind of wanting to be here, not wanting to be alive. So, I mean, these thoughts can vary in terms of intensity or frequency. So part of the assessment is just to assess whether the client is actually how we can best manage these risks. So whether to help safely manage the risk as well. So sometimes people could, I mean, it's like a spectrum of these dark thoughts. On the one end, people might tell you, what's the point of, they don't see the point of living. They might just say, oh, I'd rather sleep and not wake up. And then, but if things get more serious, they might start actually having thoughts of, oh, what if I die? And then they start having thoughts of what we call suicidal thoughts. It's that they start thinking that they might do something to themselves. But in more serious cases, then they might actually, this is kind of preoccupy them so much that they're actually thinking of acting on these thoughts. Obviously, in those cases, they are more risky, and we need to make sure that we give them the right support to help them go through this crisis.
And what would that support look like if you were putting that support in place for someone?
Yeah, so I think, for example, taking an example of people with mom with OCD, obviously, first thing we start with is we think of always try to kind of help and treat them in their natural environment. So the community or the home environment is the best place that we hopefully to start with. So a lot of people with OCDs, they're probably already under a community mental health service. They'll have a key worker who could be a psychiatric nurse, or an occupational therapist, that will kind of see them regularly. But when people go through crisis, that level of support might not be enough. So in mental health, we have something called the home treatment team or the crisis team. So the people who are actually going through a mental health crisis, then we can help to kind of support them by visiting them more frequently, daily, sometimes even if necessary, like twice daily, to help support them. So that's the crisis of the home treatment team. That's something obviously we'll do the risk assessment, and we'll see if that team is suitable and may be able to support them.
That's really helpful to know. And what about if it's even more severe than that? Say if I'm really, really can't keep myself safe, but I'm so worried about disclosing in case I get separated from my baby, if I need an inpatient treatment, is there any option to stay with my baby and be an inpatient?
Oh, yes, there is. Obviously, we know in more kind of riskier cases, sometimes to manage the risk, we might have to think of a kind of inpatient environment. And in that case, for the mother, I think first thing we'll kind of assess. We'll try to refer them to the mother baby unit, which is a kind of an inpatient setting where the mom to receive treatment and the baby stays there with them.
That's really helpful to know, because I suppose that's a very rare, tiny subset of cases, but it's just helpful to know every possible outcome of a psychiatric assessment. And mother and baby are really lovely places. We've made another video about them. So it's just good to know everything that could possibly follow. So what happens once the assessment is completed? Do you write a report, or what's the next kind of steps?
I guess the assessment will be, I guess we'll assess what the symptoms are, and if they haven't had a diagnosis already, but if they meet the criteria, then we'll give them a diagnosis of the condition. And also we'll also part of the assessment will contain a management plan, and so it will possibly will include, well, usually that's very often it's a multidisciplinary kind of management plan. I mean, from psychiatry point of view, we could explore potentially medication that could be helpful for OCD. At the same time, we can look at sort of psychological therapies. And so we usually, after an assessment, we meet together as a team to discuss the best treatment for the patient. And obviously we'll keep them in the loop, and we can, if necessary, we can offer a follow-up to kind of discuss the plan in more detail. And obviously we will, when we write a report, then they will have the copy. We also, with the consent, send a copy to their GP and to any teams that might be kind of looking after them already, like their community mental health team. So everyone's on the same page.
That's great. And I'm glad you mentioned diagnosis, because I guess that's one of the very specific things about a psychiatrist in particular, that they would be looking to give an official diagnosis. Again, that's a bit of a difference to talking to a GP or a psychologist, that you can issue an official diagnosis. And you also mentioned medication, because I know here at CADAT, for example, the GP could prescribe an SSRI, like an antidepressant, but for very severe OCD, the NICE guidelines indicates that you might augment that SSRI with different category of medication called neuroleptics. So that might be, again, thinking about first question about what's the purpose of the assessment. I suppose that's another purpose that, you know, only a psychiatrist could, a psychiatrist is best placed to think about those like more advanced medication options, aren't they, for someone with severe OCD?
Yeah. If we do offer a trial of a medication, then obviously we'll discuss with the patient. We kind of come to a decision collaboratively. We'll explain how the medication works, any common side effects. But once we start the medication or make any changes to the dose afterwards, we always we book a follow-up appointment just to check that they're getting on okay with the medication.
What if I'm like worried about medication because I'm breastfeeding, for example? Is that something you would be willing to like discuss with me as a psychiatrist?
Definitely, yes. I mean, it's quite a common kind of concerns, and we deal with these cases quite a lot. We can there's a lot of different options of medication, so we can look into that, definitely. Yeah.
Okay, so I shouldn't be put off the whole notion of medication just because I'm pregnant or breastfeeding. There might still be options for me, is what you're saying.
No, yes, yeah. There are certain medications that people can be on it and can still breastfeed. Yeah.
Right. This has been really helpful, Paul. So let me just summarize. So when I come to meet with you with OCD, you're going to be asking me all about the OCD, how it impacts me. You're going to be doing a bit of a mental state assessment, potentially risk assessment if needed. You're going to find out about my background and my history, you know, when the problem first developed, if it predates the perinatal period or not. And you're going to be kind of pulling all that information together, probably give me a diagnosis if I don't have one already. Looking into my medication, maybe tweaking it, or maybe starting on a medication if I'm not already on one. Then you're going to write everything up in a report. What if I disagree with something in the report? What can I do then?
If you disagree, do get in touch with us. I mean, after we send the report, we're happy to kind of offer more appointment to kind of go through it with you and just to kind of clarify anything. That's not the problem at all. Yeah.
Lovely. I think that's everything then, Paul. Thank you so much for speaking to me. This has been so helpful.
Oh, not at all. Thank you for having me.